I'm Alyssa Anchong-Lau, your Medcorp Limited host for today. Welcome to our live webinar series, Connection and Care in an Era of Social Distancing. Today, we'll be discussing cancer with Dr. Peter Bovell. Dr. Bovell is a radiation oncologist trained in the United Kingdom. He was the director of the National Radiotherapy Center in St. James Medical Complex in Trinidad from 2005 to 2011. Since then, he's been the clinical director of the Brian Lara Cancer Treatment Center in Woodbrook in Trinidad. Dr. Bovell, welcome and thank you for being with us today.
Good morning, Alicia. Good morning to your participants. I've been asked to host a discussion on cancer, a topic which is changing as we speak. However, I intend to give you, it's gone. I'm not seeing you, but I'll continue. However, I intend to give you in time allotted a very simplified version of Cancer 101, and then we can expand on certain areas during the question and answer period. What is cancer? Tumor formation is the result of unregulated cell division. Cells in the body are changing all the time, and there's a controlled balance between cell division or new cell formation and cell death. When cellular changes cause cells to divide when they're not supposed to, don't stop dividing when they're supposed to, and don't die when they should, that results in tumor formation. Tumors are either benign, non-cancerous, or malignant, cancerous. Benign tumors remain in their initial location and do not invade other tissues. Tumors, however, that can have the capacity to spread or metastasize are called malignant tumors or cancer. How do malignant tumors spread? There are three main ways that cancerous tumors metastasize. Either locally, invading nearby tissues, via the lymphatics, lymphatic spread, or hematogenous spread, which is via the bloodstream. Now, I'm going to give a very broad, using a breast lump as a protocol for what you do when you find a lump either in your breast or anywhere else. And this is a general protocol for most, if not all, cancers. The first thing you do is to confirm whether you do or do not have a cancer. And so you have to do a biopsy, which is sending a piece of the tumor for a histological diagnosis. If this is confirmed, then the next step is to stage the disease. Is your cancer localized to where it presented, or has it already spread or metastasized to other areas of the body? There are investigations to do this, i.e. PET CTs, CT scans, MRIs, etc. Based on your staging investigations, a decision will then be taken whether your tumor is operable, meaning surgery to remove it, or whether it is inoperable. And so we can now speak a little more about the treatment of cancer. There are four main modalities of treatment. Surgery, to remove the tumor completely if possible. Chemotherapy, medications used to kill cancerous cells. Radiation therapy or immunotherapy, medications and other treatments used to boost the immune system. Surgery and radiation therapy are localized treatments which target the area of cancer and are given to prevent local recurrence. Chemotherapy and immunotherapy are systemic treatments and are given to prevent systemic recurrence. Only two of the above four treatments mentioned are given at the Brian Lara Cancer Treatment Center. Chemotherapy is delivered by Dr. Kavi Capildeo, and I and my very capable team are responsible for the delivery of radiation therapy. So what is radiation therapy? Radiation therapy is the use of high energy radiation to damage the DNA in cancer cells and destroy their ability to divide and grow. It can be delivered using machines called linear accelerators or via radioactive isotopes, which are placed inside the patient for a specific period of time. The former is called external beam radiation therapy, where a linear accelerator is used to accelerate electrons to produce X-rays or gamma rays. The latter is called brachytherapy, where the radioactive sources are sealed in needles, seeds, wires, or catheters, and implanted directly into or near a tumor on a temporary or permanent basis. Brachytherapy is used very often in the treatment of cancers of the prostate, endometrium, cervix, or breast. Now let's go back a little to where the biopsy has come back positive. All cancers have prognostic factors. After surgery, for example, chemotherapy, radiation therapy, or both. Now, given the present situation, I am obliged to say something about what we are doing at the Brian Lara Cancer Treatment Center during the COVID-19 pandemic. I have looked at the WHO and CDC guidelines, but the one I like best, and this is the one we are following at the Brian Lara Cancer Treatment Center, is an article published on behalf of the European Society for Radiotherapy and Oncology, where there were 121 global contributors, and it is called Global Radiation Oncology's Targeted Response for Pandemic Preparedness. Most patients who are referred for radiation therapy are immunocompromised, having had either neoadjuvant, adjuvant, or definitive chemotherapy, and so they are much more susceptible to infection. So a problem arises with the control of infection between patients and staff, especially the radiation therapists, who are usually in close contact with these patients and are at high risk of exposure. We have instituted screening before patients arrive at the facility and on entrance to the facility, and are also marshalling the waiting area between patients. Patients who are well into their treatments, we have continued on the same prescription. With new patients, appropriate treatment decisions the patients benefit. The risk-benefit ratio of treatment changes in the context of a pandemic. If the likelihood of serious infection increases, or the likelihood of the outcome of that infection becoming more serious increases, then the risk may start to outweigh the benefit. Now I've divided this into three main categories: adjuvant treatments, radical treatments, and palliative treatments. In adjuvant treatments, if a patient is being offered radiotherapy as an adjunct to prior surgery, then a careful estimation of risk-benefit is required to justify the treatment. Patients who may only gain modest benefit in terms of long-term survival gains may wish to avoid radiotherapy during a pandemic. Treatments which reduce local regional recurrence rates but do not improve survival might also have reduced priority during a pandemic, and it may be appropriate to avoid radiotherapy. Radical treatments. Where radiotherapy is being delivered for cure, there may be no reasonable alternative to proceeding with treatment at the earliest opportunity. If, however, disease biology allows for a delay in treatment, for example, in the cases of hormonally responsive breast and prostate cancers, then deferring treatment until an expected fall in COVID-19 cases is sensible. Palliative treatments. For patients receiving radiation for symptom relief, it is best to ensure that all other options having been fully explored, for example, maximizing analgesia, before the smallest number of fractions given to gain a therapeutic response is embarked upon. And finally, the use of combination chemoradiation is likely to have a very significant increase in morbidity and mortality from synchronous COVID-19 infection. And the decision to delay treatment is usually discussed with the patient. Thank you, Alicia.
Thank you, Dr. Boval. We have a question from one of our attendees. What do you advise cancer patients to do to boost their immunity, especially at this time?
Well, I am not an immunologist, so I think the nutrition is important, and also getting their blood indices back to where they were before they embarked on chemotherapy. That would be the two main important things.
And how would you go about doing the latter? Is that something that they can do themselves?
No, well, we look at their blood counts. We look at their blood counts on arrival, and if they need boosting, their drugs, that injections that they can have. Well, usually it's their white cell count that's down, and that requires an injection, which they will boost their white cell count very quickly, right? If their platelets are down, well, that takes a while, and we just have to rest them and let it come up slowly. And if their hemoglobin is down, well, that can be easily brought up either with hematinic drugs or injections, as the case may be. Talk a little bit about, in the meantime, about the fact that we are in the process of upgrading our machine to a state-of-the-art TrueBeam, which should have been on its way, but because of coronavirus, it's probably delayed. But that would increase our techniques here, giving us things like respiratory gating and rapid arc techniques, etc. So we, in short time, we should have the best possible machine in Trinidad and Tobago.
And what does that mean for the medical layperson?
Oh, all right. Let me tell you what that is.
Does that mean the treatment is more precise?
All right, I'll deal with respiratory gating. Respiratory gating is a strategy designed to control or reduce respiratory movements during radiotherapy. 5 main strategies are used to reduce respiratory motion effects. Integration of respiratory movements into the treatment planning. Forced shallow breathing with abdominal compression. Breath holding techniques. Respiratory gating techniques and tracking techniques. Respiratory gated radiotherapy offers a significant potential for improvement in the irradiation of tumor sites affected by respiratory motion, such as lung, breast, or liver. What it is that you can build in the patient's respiratory motion into the treatment planning, so that it's an easy flow of treating or not treating when they're breathing, and it moves smoothly. I can tell you a little more about rapid arc. Rapid arc radiotherapy technology produced by Varian Medical is an radiation dose so that it conforms closely to the 3-dimensional shape of the tumor. This means more radiation to the tumor and less to the nearby healthy tissue. Rapid arc delivers radiation with a single 360-degree rotation of the linear accelerator. This takes less than 2 minutes. So your treatment is much faster and rapider. You can treat many more patients in a day.
Does that shorten the actual session for the patient?
Yes, considerably.
Right. So I think that we're finished with our question and answer period at the moment. So I'd just like to thank you, Dr. Bovell, for making time for us today. We can see that from your lab coat that you are at work, so we'll let you get back to that. I want to thank everybody who attended today's live webinar. Please register for the rest of our webinars this week if you haven't already done so. We're going to be talking about how to protect your kidney health tomorrow. And we also have some great sessions lined up to discuss diabetes, as well as how we can best cope with the added stress that coronavirus has brought to daily life. The details about webinar registration can be found on St. Clair Medical Center's Facebook page.
Thank you, Alicia.
You're welcome, and have a great afternoon, and see you all tomorrow.